Good morning and good afternoon. Welcome to this quarter's Global PrEP Learning Network. Please introduce yourself in the chat if you feel comfortable. And I'm going to turn it over to Carolyn, who will be facilitating for us today.
Right. Thank you, Lorraine. So good morning, good afternoon, everyone. I'm Caroline Akello, and I work with FHI 360 as a MOSAIC project director in Uganda. This topic today is very close to my heart, and I'm privileged. We are privileged this morning or this afternoon to join the Global PrEP Learning Network on strengthening gender-based violence response in PrEP services. Next slide, please. Today we have a great panel of speakers whom I will introduce shortly, and we'll delve into the agenda that is laid out on the screen. So I will introduce them shortly, and then we'll go through a gender-based violence and PrEP services overview. And then we'll go through the realities of PrEP services in the context of GBV, paths to a competent GBV response, and then we'll have audience question and answer, and then we will thereafter conclude. So I would like to ask us to pack our questions in the chat so that we'll be able to interact at the end, because we have a very short time. Yes. So without much further ado, next slide, please. I would like to introduce this great panel. First will be Morgan Garcia, who's the MOSAIC technical advisor. She works with FHI 360 in US. And Morgan leads the gender integration and meaningful youth engagement efforts for the MOSAIC project, focusing on increased leadership of AGYW and other marginalized groups, and also improved GBV responsiveness in PrEP services that she's very passionate about. And then we'll have Mary Mugure, who's a paralegal at the Bar Hostess Empowerment and Support Program, the BHESP, and she advocates for the rights and safety of sex workers and children, ensuring that sex workers understand their legal rights in the workspace. And this organization is based in Kenya. Next slide, please. And with her is Jennifer Gacheru, and they'll both speak during their session. Jennifer Gacheru also is a project manager and a project coordinator at BHESP, and a healthcare professional with more than 10 years of experience in clinical practice and public health, focusing on HIV/AIDS prevention and support for key and vulnerable populations. And then next we'll have Mercy Louis Katoka, who's a program officer in prevention and the Next Gen Squad member for FHI 360 in Zambia. She is a South-to-South Learning Network champion, and she has co-authored multiple publications about AGYW's preferences for PrEP methods and integrating GBV and HIV services. And finally, we'll hear from Alwedo Immaculate, who's a site study coordinator and QI coach at the TASO Support Organization in Uganda. Immaculate is a public health researcher based at Gulu Regional Referral Hospital in Uganda, where she provides technical leadership and implementation of quality improvement initiatives to foreground the enhanced service delivery package. So this is a great panel indeed. And I would like to now ask Morgan to set the stage for us. Morgan, please take it away. Thank you.
Thanks so much, Carolyn. I'm really happy to be here and provide this overview of GBV and PrEP services ahead of all of the really fantastic panelists we have with us today. So as many of you know, I would like to start by sharing that we know that HIV prevention often occurs in a broader context of a very high prevalence of gender-based the people we're trying to reach. And although lots of different studies have defined gender-based violence and intimate partner violence differently, we've also seen in recent meta-analyses that the estimated lifetime prevalence of intimate partner violence among women in sub-Saharan Africa may be as high as 44%. We also know that although there's many challenges to collecting data on GBV among underrepresented populations, we're seeing really similar findings among these groups. For example, among sex workers of all genders, the lifetime prevalence of intimate partner violence may reach as high as 64%. And among people who inject drugs, especially women who inject drugs, we're seeing studies that show that up to 71% of them may have experienced serious physical injury as a result of intimate partner violence in some contexts. And among trans and gender diverse people, we are seeing some gender-based violence prevalences as high as 89%. And among gay, bisexual, and other men who have sex with men, some estimates indicate that the lifetime prevalence of intimate partner violence may be as high as 78%. So in spite of these very high statistics, we also know that these groups often face a lot of violence from their community and from authority figures. And before we go forward, I wanted to share just that we are talking about intimate partner violence and sexual violence specifically, although there are multiple forms of gender-based violence, such as early and child marriage or female genital mutilation, that may also contribute to HIV prevalence. Next slide. So before we move forward, I also wanted to really highlight that although it's often used as an excuse for violence, PrEP use is never a cause of gender-based violence. So we hear a lot in our work that someone was discovered to be using PrEP and their partner became violent. And so, you know, the conclusion that people come to is that PrEP has caused the violence. That's actually not the case. So it's really that people who use violence to gain power may prevent others from using PrEP as a means of exerting power and control. So it's always takes a person who chooses to use violence, and it's not PrEP that is actually causing the violence. Next slide. With all of that said, there are some really excellent requirements and standards for gender-based violence screening and support within PrEP programs. So PEPFAR requires service providers to conduct routine inquiry about gender-based violence with all of their PrEP clients. And the World Health Organization has outlined minimum requirements that must be met before providers can do this type of routine inquiry. And these requirements include things like trained staff, standard operating procedures, and more. And PEPFAR also asks that its programs follow and abide by these requirements as well. However, although a lot of progress has been made in meeting these requirements and standards, there are a lot of gaps that remain, and those gaps remain especially in the context of PrEP choice. Next slide. So thinking about what we know about the relationship between PrEP and gender-based violence, and I'll start by saying we know it's complex. Gender-based violence and PrEP are reciprocal entry points, and what this means is that the factors that increase the likelihood that someone might be exposed to HIV also increase the likelihood that they might experience gender-based violence. Those underlying causes of HIV exposure and GBV, like gender inequality and economic inequality, are the same. And so it gives us the situation where people who seek GBV or HIV-related care, including post-exposure prophylaxis or PrEP, are really likely to benefit from both services. And this becomes even more true as we think about marginalized communities, such as sex workers and sexual and gender minorities. And within that context, it actually means that we have an opportunity to reach a broader population with person-centered and trauma-informed services, prevent more HIV, and respond more effectively to more people who are experiencing violence. We also know that screening and support for gender-based violence is incredibly important within the PrEP context. So if we are able to integrate GBV screening and support into PrEP services, this also gives us an opportunity to more promptly identify and address gender-based violence. We're able to identify people who might not otherwise disclose. And we also see that robust screening and support for GBV might improve PrEP uptake and effective use. And finally, competent screening may also increase client trust in providers, so encouraging clients to come back more often and trust clients with their problems and seek help from them to address issues with using gender-based violence, using PrEP, or getting support for violence that they might be experiencing. Next slide. We also know that gender-based violence impacts effective PrEP use. So some PrEP users who experience GBV may struggle to use PrEP effectively. I think a lot of us have seen that in quite a bit of the literature and in our programs. But at the same time, we also have seen some studies that show that the age of the survivor, the recency, or the type of violence, and some other factors may also lead to improved use of PrEP after an experience of gender-based violence. So as I mentioned before, this is really complicated and we are still learning. With all of that said, effective counseling and referral services may actually mitigate the negative impacts of gender-based violence, such as the psychological burden and the fear of accidental disclosure of PrEP use. And finally, we really are very aware of the fact that we have very limited resources, and that constrains our ability to effectively integrate gender-based violence and PrEP services. So we know that the time and resources for training are incredibly limited. We don't really have adequate referral resources in most of the places where we're working. We have a lack of support for providers to be able to take care of themselves and do this work effectively. We also are experiencing the fact that the structural limitations that exist and the other barriers to disclosure related to the structures we live in are still present, and we may have limited power to actually make a difference in some of those factors. With that said, the resources and tools to overcome these challenges are absolutely crucial to help us meet the needs of people who are impacted by both HIV and violence. And we'll hear a lot more about this from our upcoming presenters. I'm really excited to hear what they have to say. And finally, I've added a lot of references here. So next slide for folks who are interested in reading more about everything I've shared. And with that, I'll hand it over to our next speakers. Thank you so much.
Wow. Thank you, Morgan, for setting the stage and really giving us a succinct overview of GBV and PrEP services. And next, I would like to welcome Mary and Jennifer to take it away. Thank you.
Hi, everyone. I'm Mary from Bar Hostess. I'll be taking you through PrEP services and in the context of GBV. Next. Reality of PrEP services in the context of GBV. As I said, I'm Mary Mugure from Bar Hostess Empowerment Program. We'll be doing it with Jennifer Gashero from the same organization. I'm a sex worker by profession, and also I'm a paralegal. Next. When we talk about gender-based violence in the HIV prevention journey of a sex worker, we know in Kenya, sex workers are being criminalized. It is not a job that is illegal, so we face a lot of illegal arrest, harassment. It is our daily life. And when we talk about gender-based, you can see that we have the common area that most of the sex workers face violence from their intimate partner. When I talk about intimate partner, is the person who maybe I'm living with, or is the person who maybe pays my bills. So some of the men take advantage of the situation because they don't understand about the PrEP drug. So it becomes violence to them. And also we have some sex workers who are not so much empowered when it comes to the context of defending themselves. So some partners take advantage of the situation and blackmail them, and it turns physical. And sex workers who take PrEP experience more violence when it comes to clients and partners because they think PrEP is a HIV drug treatment. Next. And also what we'd like policymakers and programmers to understand or to know about sex worker. To stop HIV, we need legal framework that addresses gender-based violence from partners and the broader community. The framework must support all sex workers and survivors included. So when we understand when the community have the information on PrEP, it will be better, it will be a safe place for us. As I said earlier, sex work is criminalized even in the community where we are living. So this framework would work when it is also the includers when they are doing their decision making and creating awareness to the society. I'll hand over to Jennifer.
Next slide, please. And just to add before I start in the context of provider, when you educate everyone in the community, including the men, I think we'll have reduced the cases of violence at the for sex workers. And I'll be taking you through the provider reflection on responding to gender-based violence. And for providers, we do incorporate GBV screening into routine care, whereby we refer survivors to appropriate services like counseling, legal aids, and shelters, which is a major challenge as we speak. Then we also use trauma-informed approaches by ensuring that care provided is sensitive to the emotional and also the psychological needs of our survivors. Providers also actively promote PrEP and incorporate in other HIV prevention methods to clients in need, including GBV survivors, and also clients dealing with mental health challenges, among others. Then we also do conduct outreaches to this with the purpose to raise awareness, whereby we incorporate messages about GBV and HIV prevention, mental health, and stigma, and also with a name of empowering our clients to seek help when need be. Next slide, please. With sufficient resources, providers would integrate more comprehensive services like legal assistance and also social support into healthcare setting. It's there, but it's inadequate. Building strong referral system and follow-up services to ensure survivors receive ongoing support that is beyond immediate crisis care. We also would offer more accessible and long-term support like housing, legal aid, and trauma therapy, which are often unavailable due to the limited resources that we have. We will also implement specialized interdisciplinary programs that focus specifically on GBV survivors and their unique health needs. And just to sum it up, many providers would like to work more deeply on reducing societal stigmas, which is a major challenge, and power dynamics that make GBV survivors reluctant to seek help. Next slide. What are the challenges and successes from providers' perspective? Of course, our major one is insufficient funding. If we don't have enough resources, of course, giving survivor a full package for the GBV services, it becomes a hindrance. Then we also have lack of training in GBV care, where some of the providers are not training on GBV. Then we also have burnout as a challenge from where we had to handling high emotional trauma, and also lack of referral networks. It's there, but not sufficient. We also have successes as a provider, whereby empowering survivors with comprehensive care, and also creating safe spaces where they can relax and interact with others. Then integrating HIV prevention like PrEP to GBV service, which has been a major help in sorting about GBV services. Then there is movement of hope when you empower and also you feel fulfilled as a provider. Next slide. How to responding to GBV impact providers? Of course, we have the impact when you offer GBV services, and one is emotional and psychological strain. Treating a GBV survivor can be emotionally taxing for a provider, leading to burnout or transferring the trauma to the provider, which we call secondary trauma, for whereby after witnessing the repeated trauma from the clients. Then there is also need for self-care and support. whereby counseling and peer support are very crucial to help providers cope with the emotional burden of their work, and also maybe that's what we call debriefing, and also having something like team building for the providers. Over to Caroline.
Wow. Thank you so much, Mary and Jennifer, for really speaking through the voices of sex workers, but also providers, highlighting the successes and challenges in the response to GBV. Our next speaker will be Immaculate Alwedo from TASO, who will take us through the paths to a competent GBV response in PrEP services. Immaculate, please take it away.
Thank you. Thank you very much, Dr. Carol. Good afternoon and good morning, everyone. Like Dr. Carol has introduced me, I'm called Immaculate Alwedo, the QI coach based at Gulu Regional Referral Hospital, work for TASO Uganda. And I'm here to share with you our journey on how we use quality improvement approach to improve on the GBV screening at Gulu Regional Referral Hospital. Next slide, please. So next slide, please. Next slide. Susan, are you listening to me? Yes, okay, thank you. So at Gulu Regional Referral Hospital, we are a team of 7 to 10. This is a work improvement team comprising of the QI focal person, the nurses, the data clerk, and also the peers are also together with us. And we are going to walk with you the journey that we went through to improve on gender-based violence screening for our PrEP clients. Thank you. Next slide. Next slide, please. So at Gulu Regional Referral Hospital, we have been experiencing challenges with low gender-based violence screening at a rate of 53%. We sat down as a work improvement team, of course, and we used the fishbone analysis to help us unpack the different gaps at the different thematic areas, looking at the service provider side, the client side, the system, and the community and the measurements. So the client side, clients would report to us that they are experiencing challenges to disclose, of course, fear of disclosure, then low self-esteem, fear of retaliations. As you all know that talking about GBV itself, it's a trauma itself. So most clients report that it's really very hard for them to really disclose this. Then also when you look at the community perspective, there's still stigma and cultural norms and traditional norms also around the community. Concerning GBV, most people do not really open up because they fear that they'll bring shame to the family. As of all this, the major contributing factor to us, it was mostly under measurement and evaluation. We also realized that there was stock out of GBV screening tools and failure to update the tools after the visit. This was after we did all the root cause analysis, and we realized that our baseline at 53% was really contributing much to stockouts of GBV screening tools and failure to update this. So we came up with workable solutions to this, and we had very many suggested change ideas like availing the MOSAIC screening tools for Uganda to support us with GBV screening and also improving on our documentation. So with this, we had to prioritize this change idea because it was feasible for us, and we believe that it would use low efforts to give us much impact. So this is how we ended up availing the GBV screening tools to improve the GBV screening services. Next slide, please. So our objective was to improve gender-based violence screening from 53% to 80% between the month of June and November 2024. And here we've been working this journey. We started working this journey from June up to date, and as I talk of now, it's still continuing. So we ran through the different PDSA cycles 1, 2, and 3. We started with 1, and 1 in particular, we just availed the tools. If the tools are available, what will the providers do? And the good thing for us is the providers were really interested. The uptake was really so good. They were willing to really support and screen these clients, because when you screen for GBV, you're going to see high PrEP uptake and also retention. So when we started, of course, our screening rates was at 45%, and all those who disclose experiencing GBV were offered support at 100%. At the end of PDSA cycle 1, we realized that, of course, we had gaps. When you look at 45%, it is way below our expectations. Of course, we were fighting to go beyond 53, but again, we dropped to 45%. We had to again go back again. We did more root cause analysis. We brainstormed what could be the problem. We are screening, but to realize that there was inconsistent screening, that is one. There was also still incomplete documentation. And also the providers reported, of course, low knowledge on how to screen and to manage these clients. Then also we had inconsistent supplies of the GBV screening tools. So we again sat back and we were like, no, let us try this to another level. So we went to PDSA cycle 2. And in PDSA cycle 2, we were now just refining the challenges, like way forward on how we can improve this. So in PDSA cycle 2, we conducted the life refresher training for the staffs, including also our peers, empowering them, because one of the challenges was also workload. So when we empowered the peer, the service providers were able to delegate the roles to these peers. And with this, we also had other facilitators to improve on GBV screening, like attaching the GBV screening tools to the client's card. We also had something around on-site mentorship on the different tools, and also conducting on how to manage the GBV screening. So with this, our screening rates actually increased to 62%. By 62%, we realized that we really rose from 45%. And we have been having interaction with very many different teams who really support us. We have IPs in the region, the TASO management team, and also the FHI Global team have been having routine check-ins with us. And with this, at the end of PDSA 2, we had to increase this and scale it up to the community. How are we really conducting this community-based GBV sensitization? With community-based sensitization, we scaled this up because we saw it work by the end of PDSA cycle 2. So with community-based organization, we normally just integrate these activities into what the community-based organizations are doing, or during different outreaches, or even when the peers are in their own, like in the evening hours. So the peers started screening. Of course, we had empowered them already. We gave them the screening tools. IEC materials also came during the refresher training. They would use it for sensitization during community outreaches. Also, the service providers themselves started screening in the community. And all the participants or clients who report experiencing GBV were really supported. And with this, we saw an increase to 78%. That is numbers of clients screened, and all these were really supported. We had strong linkages and referral system by then, because we had now to involve other stakeholders to come in and support us. Thank you very much. Next slide, please. So generally, as a QI measurement tool, as you can see from our run chart, we really noted a great improvement over time, but also we observed some bottlenecks that we continue to address throughout the PDSA cycles. As I talk right now, we are still in PDSA cycle 3 and we're still running until the end of the month. But as you can see in PDSA cycle 1, we had really a drop that is 45%, way below the median. But with refinement of the challenges that we experience, we can now see that our GBV screening is way above the baseline median, and it has continued to stay throughout the PDSA cycles, even in 3 that I'm talking about right now. This, of course, shows that these are statistically significant improvement, and when we base on the numbers and also the rules of interpretation, we are going to see that the numbers of runs at the PDSA cycle 1 reduce, and also when we see in PDSA cycle 2 and 3, we can see there's an upward shift and also a trend all through. All these are statistically significant improvement, and by the end of this, we really aim to strengthen more and more of the GBV screening. Thank you. Next slide. Next slide, please. I would love to pause and then share with you what lessons did we learn from this. Like I said before, we started this journey from June up to date. Of course, we learned that privacy, confidentiality is really very key in offering gender-based violence services. When you give a client a safe space, and when you attend to them openly, having an open mind, open-ended questions, they are able to really open up to you with enough conducive environment. Of course, collaboration with other IPs. Like I said, we had Uganda Health Activity. We had other IPs coming in to support us, both at the linkages, even at the screening, and also the support system. Then also we saw providers and peers really being inspired to take up this role. Of course, when you see you're following your clients very well, and at the end of the day, you see them really adhering well to all these PrEP services. Yes. Then also we realize that clients who are in long distance relationship prefer not to really disclose PrEP use, and sometimes it is their choice not to disclose. Yes, also offering service client satisfaction survey, it's really very, very key. There are some clients that we would realize at the exit point when they're exiting the facility, when you give them the exit surveys, and mostly the questions for our exit surveys for the Catalyst study that ask about privacy and method switch, these clients again will start talking, yeah, I think I like this so well, and the method switch will really work for me and my partner. Yeah, it has really, really, really greatly supported us. What are the implementation challenges? Of course, where there are success, at least there is some minimal also challenges alongside. So we have also experienced climatic changes that we have continued to address all through, and inconsistent outreaches that we continued to really talk to the IPs and also integrate our services at the best minimal solution that we can do. Next slide, please. So thank you very much. Apparently, we are still screening. Like I said, we are now at the community, joining it together with the facility-based GBV screening, and there's still sensitization. The sensitizations are being done by our peers with the IEC materials. We are still attaching the GBV screening tools and referral forms to the client's card. This is like a facilitator to GBV screening. As a service provider is picking the card to screen, they're able to see the GBV form attached to it, and they'll be able to screen. There's delegations of role. Refresher training is ongoing, on-site mentorship, mostly for the new staffs, the new peers. Yes, and by the end of this month, we really plan to adapt this change idea. When we adapt, and we shall develop guidance for implementation, and also we may end up scaling up to the rest of the facilities. Thank you very much. Next slide, please. Lastly, many people have contributed to this. I would love to really acknowledge the TASO management team, the Ministry of Health with Gulu Regional Referral Hospital Work Improvement Team, FHI 360 in the US, and our implementing partners within the region for supporting us, and also for acknowledging them for everything that they've done for us. Thank you very much.
We have some questions here in the chat, and thank you for really closely listening. So one question that goes out to you, Immaculate, just a clarification, I believe, is was the low GBV screening in the context of PrEP service delivery? How did you identify this challenge? How did you identify that? Yes, please go ahead.
Okay, thank you very much. As we all know that gender-based violence is one of the packages for enhanced service delivery. So every PrEP client or any other client seeking for health services must receive all these enhanced services. So with us, we have been really excelling in other services, like we screen them for HIV, and we screen them for family planning, we screen them for STIs, but we have been lagging behind with GBV screening. Here we evidence with our different data tools as during our assessment, and when we were deriving our baseline data, we realized that there was incomplete documentation, one, then another one, there was really no screening for clients. It was really way lag behind. Yes. Thank you very much. I hope I've answered. Thank you.
Yes. Thank you for really clarifying that. Yes, you have done very well. So I would also like to reiterate a comment here for Mary. Yes, so Mary, just wanted, a question here is for you, is that how do sex workers feel about the availability of new PrEP products? For example, CAB and the ring. Do you think that this will be easier for sex workers to use? But also, as a paralegal and an advocate for sex workers, could you say more about the support that you provide to sex workers who have experienced violence? For example, the peers, people that have experienced sex, violence, how do you handle that? We just want to hear your perspective, if you don't mind. Thank you.
Okay, hi, once again. I'll start with to respond with the first question that you have asked about the prepping and CAB. Actually, we are very happy. We have seen it. It has a very big impact in the society of sex workers, because right now even the cases of IPV has gone down. It's not like before. Before we had a lot of cases every now and then from clients, from even police themselves when they arrest you with the container of PrEP. But right now, since the prepping was introduced, we have seen it is working, and still we are hoping for the best, because we are waiting for the CAB to be to start working, because ring is inserted inside. The injection will come, nobody will know that you are preventing yourself. So we believe it will work in a broader way and better way. According to the second question that you have asked, how will we help the survivors of GBV? There is a lot of things we do. We have support groups where we sit down with them and talk our challenges. We also do referral, because there are those that maybe they need to be talked a bit. We have social support program, which we talk our things that we are doing, and also we have psychology in our dice, who we usually refer to. When the client comes, she was violated, she was beaten, and maybe she's going through a lot of trauma, or you see she's not okay, we refer her to the psychologist. So that is the biggest part that we play. And I do follow up. I do follow up with them, because there are those clients that we take them to police station. Even we have a lot of cases that are ongoing, where perpetrators are being arrested after doing whatever they have done. We don't take it just for granted. We have to do follow up with our clients to make sure that they have justice, because nobody has a right to humiliate you, or neither beat you or abuse you because you're using prevention measure. I hope I've
Yes.
answered your question.
Wow, thank you so much, Mary, for sharing your experience, but also the work that you do in supporting the sex workers. That's really amazing. I would now like to go back to the presentation. Mercy, Louis, please take it away. Thank you.
Thank you so much, Dr. Caroline. Good morning, good afternoon, everyone. Apologies once again. So as earlier introduced, my name is Mercy Louis Katoka, and I am a prevention program officer, as well as a member of the Next Gen Squad. And I also serve as the safeguarding focal point person for the MOSAIC project here in Zambia. And today I'm just going to share about the work that we've done in supporting the Ministry of Health to leverage pre-exposure prophylaxis rollout just to improve GBV response here in Zambia. Next slide. So as Morgan previously touched on, gender-based violence still remains a significant barrier when it comes to accessing HIV prevention products as well as services like PrEP. And this is particularly true for Zambia. And in the second quarter of 2023 alone, nearly 10,000 cases of GBV were recorded, which just underscored the need for integrated services. And also, while efforts are being made to incorporate sexual and reproductive health considerations even into the HIV policy, as well as practices in Zambia, there still are some shortcomings when it comes to addressing GBV support, even within the PrEP program. And so the introduction of new PrEP products, such as the recently launched CAB PrEP in Zambia, earlier this year, just presented a crucial opportunity for us to be able to address GBV alongside HIV prevention efforts. Next slide. So the FHI 360 MOSAIC project supported the Ministry of Health in incorporating gender-based violence screening even into PrEP monitoring and evaluation systems. We just aligned these services with also the global health standards, which is PEPFAR as well as WHO that Morgan talked about. And the MOSAIC project played a very crucial role in developing as well as integrating GBV even in the national PrEP as well as PEP guidelines, which were also launched early this year when PrEP was launched, and also including the integration of the WHO's guidelines input even into the PrEP clinical management tools. And the project also provided tailored training for health workers to be able to screen for intimate partner violence even within PrEP services. So we did train the Ministry of Health staff for them to be able to provide live support even in the PrEP setting, and also to screen for intimate partner violence. Next slide. And in addition, we also supported the Ministry of Health with technical input when it came to the development of the national PEP as well as PrEP guidelines, and the MOSAIC Charisma standard operating procedure and the job ed were referenced even in the integration of intimate partner violence screening for PEP as well as PrEP services, which was included even in the PEP and PrEP guidelines. And the SOP guidance just helps PrEP programs to meet the minimum WHO requirements for GBV screening. And on your screen there, you're able to see a code. And if you scan it, it's gonna take you to the Charisma standard operating procedures, which were referenced even in the work that we did to support the Ministry of Health. And this also just included the listening, inquiring, validation, enhancement of safety, as well as providing support first line support response, even in the PrEP training manuals for the healthcare workers. And we also just supported the Ministry of Health PrEP providers with the training of the WHO lives approach. And this content was tailored to meet the needs of the PrEP providers, like I earlier mentioned. Next slide. So when it comes to some key lessons that we learned and also some key success factors, we did realize that there was so much government enthusiasm when it came to the integration of GBV as well as HIV prevention. The Ministry of Health made it so easy for us to be able to support them, even to integrate GBV into HIV prevention, and also the strengthening of the existing health systems for better service delivery was another key lesson that we learned. And the fact that we needed to include, or we had actually GBV experts as part of the core team, and these included GBV experts from the Ministry of Health, but then also under the MOSAIC project in Zambia, we had a dedicated GBV gender staff that helped with this work. And as part of another key success factor, the fact that we had supportive policies that facilitated GBV integration, even in the national PrEP program, also just made it easy. And the fact that the continuous workforce training to ensure sustainability was also something that we did take into consideration. Next slide. So when it comes to the impact, we saw that the integration of GBV prevention as well as response in Zambia's PrEP program are supported by the MOSAIC project did mark a pivotal advancement when it comes to combating HIV, especially amongst women as well as children, by addressing critical gaps in policy as well as practices, and also just mitigating the negative gender norms that perpetuate GBV. And by incorporating gender-based violence screening as well as response even into the PrEP service, coupled with, of course, comprehensive training and standardized protocols, we do believe that Zambia is aligning with the global standards set by PEPFAR as well as WHO. And this approach just paves the way forward for gender transformative HIV prevention initiatives, and also our sustainable impact, and just ensuring a survivor-centered as well as a trauma-informed approach, even when it comes to addressing GBV within the PrEP program. Next slide. And in conclusion, I would like to just urge all of us to utilize opportunities that we have now, such as the rollout of new HIV prevention methods. We've seen a lot of options that have come into the market. We have PrEP on board, we have the ring, and we now have lenacapavir, and there's more that are yet to come. So it's just an urge for all of us to be able to utilize opportunities that we have now to be able to integrate and improve our GBV response. And in terms of sustainability, it's just important to also consider strengthening of national capacity, national policies, as well as the workforce training, just to ensure continued integration and effective GBV response. This is the end of my presentation. I'm gonna hand it back to Dr. Caroline. Thank you.
Wow. Thank you so much, Mercy Louis, for that. And we want to thank you and the Zambia team for sharing your experiences in seeing how to actually advocate, how you successfully advocated for inclusion of GBV screening in guidelines, but also ensuring that providers are really trained appropriately. So that is really amazing. And I believe our country teams are truly going to learn from you. Yes, we're going to share this slide so that we're able to also really read into this and be able to see what the Zambia team did and maybe advocate also for the different countries. So we have at least, been better users of our time. We have about 5 minutes more for question and answers. If someone has a burning question, you can unmute and be able to speak up. However, we also have had some questions in the chat, and I would like to read some of these. There is one question that came in, and maybe this goes on to Immaculate about the PrEP register. Does your PrEP register have a provision for documenting GBV screening so that you're able to demonstrate screening coverage? But also, as Immaculate is thinking of responding to that, I would also like to talk about, to bring up this question from someone about community, about, where is it? And maybe this can be responded to by both Mary, Jennifer, but also Immaculate or any of the panelists. When we're screening for GBV within PrEP service offerings, how do we ensure that providers don't interpret this as a counter indication for PrEP? For index case testing, for example, a positive GBV screen is an indicator not to do partner notification, but disclosure of GBV should not limit PrEP initiation in the same way. So the question really is, how do we make sure that providers tailor their effective PrEP use counseling in response to GBV disclosure? I think this is really very important, and I would like maybe Jennifer to respond to this, given that she is a healthcare provider that has been providing PrEP. Yeah, so over to you, Immaculate, and then Jennifer, and then we can take more questions. Please feel free to unmute and really ask our panelists who are really experts in this. Thank you, and over to you, Immaculate.
Thank you very much, Dr. Caro. Going straight to the question concerning the PrEP register, yes, we do have a column for GBV screening, and at every visit, let's say at initiation, then at follow-up of every PrEP clinic visit, all these clients are documented in the PrEP register. Alongside the PrEP register, we also have other primary tools that we use to capture whether they're screened or not. We have the HIV prevention service tracking cards. It has also acted as one of the primary tools. Then we have the KPPP prevention register. At least there is a column that even when these clients are not screened with the MOH screening tools, we are able to really track these clients down up to the PrEP register and find out if they were screened or not. But like I said before, the MOH screening tool, it's like a facilitator. It enhances comprehensive GBV screening. Yes, thank you very much. Back to you, Dr. Caro.
Okay, thank you. And over to you, Jennifer, to respond to the question of the providers. how do we make sure that providers tailor their effective PrEP use counseling in response to GBV disclosure, so that it's not a turn-off for people to really disclose their use, their PrEP use? Jennifer, if you're speaking, you're muted.
I am here. Thank you for that. To ensure that it's not a turn off, we ensure that we do comprehensive counseling, and it's not only done for those who are being initiated or referred for PrEP. And we also make sure we screen for intimate partner violence, and at any point that we are starting plans on PrEP. Over to you.
Okay, so it is very important to really provide comprehensive information about the PrEP methods and really counsel them comprehensively before. Yeah, that's really important. Thank you, Jennifer. Another question, and maybe this could go to Mary. When you're doing community education for GBV, do you also target the perpetrators? Or is it only that, do you target the perpetrators as well, or do you just target women who are at home, and then we leave out the male counterparts who contribute to the large number of perpetrators? So she really, someone wants to just find out, given that she is a paralegal and she has seen that most times we are targeting women and not really targeting the men out there who actually are the perpetrators of this violence. What do you say about this, Mary?
Thank you for that question. First of all, I would like to tell you, when we are doing community awareness, we don't only target women only. We have something we call CAB, Community Advisory Board, where we include chief, community elder. We also include police. Then we call the people who are own clubs where these girls hang around. We call waiters and bouncers. Those are even men, even themselves, they are men. Then we call sex workers to come and talk. We put it like an open discussion, open group discussion, where we discuss our issues and we make sure that they understand what you're going through. We don't leave men behind, because we want to understand, we want them to understand what they're doing for the abusing girls or abusing sex workers. That is very wrong. And the reason why we include even police officers, because these girls have to go to the police station when they're abused to report. And we want support from the police station also. And the reason why we also include community elders, because we live in a community, we live in the same settlement. They should understand that any moment that sex workers is being abused in your area, you should stand in for the gap. So we don't only empower women. The biggest part where I empower women is that they should know their rights, that they have their rights, even though they're sex workers, they have their rights. Nobody should infringe their rights in the time of their work. They have every right to say no and remain it is no, and their decision to be respected. I hope I've answered your question.
Okay. Yes, thank you so much, Mary, for that response. Yes. Please continue putting your questions in the chat. Maybe the presenters will be able to respond to this also quietly. I know our time is fast spent, but then I would like to just read a few comments that are out there in the chat. Yes, so one of the comments from Diane is that thank you to the presenters for these very informative presentations. And she thinks that one of the first things we need to do is to shift our understanding that PrEP is for key populations, but that PrEP, that it's not for only key populations, but it's really for HIV prevention. And as such, it should be included as part of GVB prevention services. So this way we can normalize PrEP use and minimize stigma associated with PrEP as something only for key populations, so that we can really engage people who have risky behaviors. So surely offering PrEP should really go hand in hand with screening for GBV, which is really, really important. And I believe surely the message that has come through here is screening for GBV is really very key in when offering PrEP services. So that, but also, as she has said, decapitalizing PrEP is also very key to really open it up, that PrEP is really for anyone who wishes to use HIV prevention. I believe those are really key insights that you're raising there. Yes, I know there are many other comments and questions out there, and I know we have run out of time. I would like now to hand it over to Morgan to close this session. Thank you so much for your active engagement. Over to you, Morgan.
Thanks, everyone. This has been such a fantastic and informative call. I really have enjoyed seeing the questions and comments in the chat as well, and we look forward to trying to get some of the answers to these. I wanted to close today, or we wanted to close with a call to action. As mentioned before, although PrEP use is not a cause of gender-based violence, GBV really plays a role in the lives of many current and potential PrEP users. And responding to GBV is so important, as we heard from Mary and from Jennifer, and the importance of being able to do this effectively impacts people's PrEP use, as well as the well-being of providers and just the community at large. And I think, as we heard from Immaculate and Louis, we have this really amazing opportunity to invest in integrating gender-based violence and PrEP services so that we can make a greater impact on ending the epidemic and reaching everyone who can use this gender-based violence supportive response, as well as would benefit from and access to PrEP. So, I hope, and it's our hope as a group, that this presentation motivates people to invest that little bit of extra energy at the individual site level or clinic level, as well as at the national and global level, to integrate gender-based violence and PrEP and make us more successful in ending the epidemic of HIV. And the final slide here, there are several resources that folks can tap into to help get that started. And we're all happy to respond to questions and contacts as we move forward. So please do feel free to reach out to us. And thanks again, everyone, for your inputs and questions today. It's been a fantastic session.
Thank you, everyone, for joining us today. Have a wonderful rest of your day, and we will meet again in the new year.